Thank you all for coming this morning. My name is Ryan Boyles. I'm the owner and editor of Health News Illinois. We have a wonderful panel with us today to discuss probably the biggest healthcare issue facing Illinois and the rest of the nation right now, and that's trying to make sense of what's next for Medicaid. Thank you so much to our esteemed panelists for sharing some of their valuable time this morning. I am so thrilled to introduce this morning Ollie, the President and CEO of the Illinois Primary Healthcare Association, Ashley Snavely, CEO of the Illinois Healthcare Council, Director Elizabeth Whitehorn, Director of the Department of Healthcare and Family Services, Jill Hayden, CEO of the Illinois Association of Medicaid Health Plans, AJ Wilhelmi, President and CEO of the Illinois Health and Hospital Association, and Stephanie Altman, of Counsel and former Director of Healthcare Justice and Senior Director of Policy at the Shriver Center on Poverty Law. Before we get started, I want to make sure we thank our generous sponsors of the Health News event series. These discussions would not be possible without their support. So a huge thank you this morning to the Illinois Health and Hospital Association, the Illinois Primary Healthcare Association, Novo Nordisk, and Springfield Clinic. Health News Illinois is an online nonpartisan news service. In addition to events like this, we also publish a daily newsletter. If you're not a subscriber, I encourage you to sign up for a free trial. You can do so at healthnewsillinois.com. I want to give an extra thanks today to the Illinois Health and Hospital Association, today's featured sponsor. We are very grateful for their generous support. Here to say a few words today is Karen Harris, IHA's Senior Vice President and General Counsel.
Good morning, everyone, and thank you all for joining us today as we take a closer look at the potential impact of the changes to Medicaid. My name is Karen Harris, and I'm the General Counsel for the Illinois Health and Hospital Association, or IHA. On behalf of IHA's President and CEO, AJ Wilhelmi, who you'll hear from shortly, we thank the Health News Illinois for hosting today's event, and we're proud to be a sponsor. This discussion is very important to IHA and our over 200 hospitals and 40 health systems. This is a pivotal moment for our industry. The One Big Beautiful Bill Act is the largest reduction in Medicaid spending in the history of the program. $1 trillion in healthcare cuts nationally over 10 years. Here in Illinois, we expect the impact to be dramatic, with well over $2 billion in Medicaid cuts annually. Hundreds of thousands of people in our state will lose their healthcare coverage as a result of this bill. As a result of the OBBA and other federal regulatory shifts, the healthcare regulatory environment, which is never static, is evolving even more rapidly and undergoing significant transformation, which will reshape how healthcare providers, insurers, and patients receive and are reimbursed for care. From new compliance requirements to policy shifts and technology advancements, the need to stay informed and adaptive has never been more critical. As I work with hospitals, general counsels, and attorneys across the state, including serving our most vulnerable communities, the challenge is clear: figuring out how to remain compliant within new regulatory frameworks while continuing to prioritize patient outcomes in these challenging times. And that's why coming here today, together as healthcare providers, community leaders, and policymakers in discussion forums like this to chart a path forward is so important. So on behalf of AJ and the Illinois hospital community, I want to thank Health News Illinois again for hosting this discussion, but also for your continuous efforts to highlight important healthcare policies that impact us all. I look forward to hearing the presentation, and thank you.
Thank you so much, Karen. We appreciate that. Thank you so much. Before we start, I just want to let everyone know that there are still opportunities to become a sponsor of the Health News Illinois 2026 event series, both virtual and in person. Don't hesitate to reach out if you have any interest and want to learn more. Without further ado, we'll jump right into the discussion. And now, Ollie, usually I go with the person in the hot seat, but today we have an exception today. And I already told the director that I wanted to start with her today. And Director Whitehorn, I wonder if you could just kind of set the table a little bit and kind of lay the groundwork for what exact changes are coming to the Illinois Medicaid program, and just maybe a quick overview of some of the steps that HFS is taking right now to prepare for this.
Hello. I guess we didn't follow directions on where to say.
No, you're good.
Well, thanks for having us here today. I wanted to just share some statistics first that I think many of you know, but just as you set up the table about the Medicaid program in Illinois and how important it is. So there are over 3.4 million Illinoisans who are covered by Medicaid. 44% of our customers are children, 9% are seniors, 7% are adults with disabilities. And another interesting statistic that we'll get to that impacts and shows the overlap of all of this work that we have to do with HR 1 is that approximately half of Medicaid customers are SNAP recipients. And on the flip side, it's about 90% of SNAP recipients who are covered by Medicaid. We cover almost 70% of nursing facility days in Illinois, 50% of all births, and approximately 60% of community health center patients are Medicaid customers. So as we all know in this room, this is a hugely important program. And yet what HR 1 does is, ultimately, though we are going to try our best to not have it do this, it will result in hundreds of thousands of people likely losing coverage, which has the potential for negative health outcomes, substantial medical debt for individuals who lose coverage, increasing uninsured rates, which then impacts our providers, especially hospitals, but all providers too, which then impacts Illinois' economy. So HR 1 really has huge ripple effects. The way we're looking at the bill, I think there's three major buckets. There's a lot in there, but bucket 1 is all of the eligibility changes, starting with work requirements, but also having to do redeterminations every 6 months for the ACA population, and also having to implement cost sharing for the first time ever in Medicaid, also for the ACA population, and then a whole bunch of other eligibility changes. Then we have changes to the provider taxes and state-directed payments, those don't go into effect for several years, but will have enormous impact on the state budget and the budgets for our hospitals especially. And then the third piece is the Rural Health Transformation Fund. So we are preparing sort of in each of those buckets as much as we can. While there's a lot of unknowns as well, and we are waiting for guidance from the federal government on a lot of this. But we can't wait that long. We've already started planning. The governor's office has convened a high-level group of agencies because we know at HFS we can't do this alone. We operate an integrated eligibility system, which is how we, as many of you know, that's how we enroll our customers. And that system is also for SNAP and TANF and other public benefits. And so we work closely with the Department of Human Services as well as the Department of Technology, do it. And then we're also, working closely with the Department of Central Management Services because we know we're going to have to expedite and find ways to get around hiring rules and procurement rules if we're really going to be able to do this. But it's going to require major IT system updates, which we are already starting to plan for and look at. And it's going to require, working in a whole new way in terms of communicating with customers so that they know, what are these work requirements, how are they going to be able to comply with them. And then on the Rural Health Transformation Fund, we're waiting, just keep hitting refresh on the website because that application was supposed to be out last week. But we'll be working really hard to get our piece of this $50 billion. So I'm happy, I don't want to take up too much at the beginning, but that's sort of how we're looking at it and happy to talk about more of those items. But I will say our ultimate goal as an administration and at HFS is to mitigate harm and keep as many people enrolled in Medicaid as possible.
Thanks so much, Director. I think you gave us a nice preview of what we're going to be discussing for the next hour, some of these different provisions. But Ollie, I do want to go to you, and I want to ask each of our panelists some variation of this. But Ollie, just what steps are you and your members taking to prepare for these upcoming changes?
Thank you. I don't know how we prepared for this, to be honest with you, but if you had asked me that on Friday, I'd have had a different answer for you. focused on potential shutdown right now. I'm flying to DC tomorrow with some of my colleagues across the country. So first thing is a shutdown, and my consultants think there's a 60% chance of that happening in the end of this month. But to answer your question, it's loaded. I'd like to say, MPC's always enjoyed bipartisan support, right? But I don't know if we have any friends in DC right now to kind of stem or help us prepare. And we tell our senators we can prepare for a shutdown. Continue to do things you do. And as you heard the director say, some of these things, the implementation for some of those programs, those cuts are delayed in certain years, 27, 28. But honestly, what we're trying to do is just make sure, just as the director said, continue serving the patients we serve as best as we can. There's a lot of uncertainty in some of the things. You might have heard of what we call parole information responsibility. There's a preliminary injunction on that. So how do we prepare for those kind of things when Section 330 grant says you need to see everybody in your catchment area? And what is catchment area? What is the federal benefit? Those are some of those things we sort of kind of need more answers on. But I wish I could give you a definitive answer, and I don't want to take too much time. It's really just be prepared, expect the worst, right? And hope that good things happen. I know that sounds like cliche, but that's the best I can give you right now.
Absolutely. And actually, I want to go to that question, but I do want to let the director know that HHS just sent out an email regarding the $50 billion healthcare transformation. So you have a little homework to do after this event. Actually, I want to go to you on that question, just from the long-term care perspective. Just kind of what are you and your members, how are you preparing for this?
Sure. So when we're looking at the federal Medicaid bill, we're certainly looking at the provisions when it's applied for Medicaid tax assessments on providers. So for nursing homes specifically, our assessment does not meet the uniformity clause in the rule that the feds put out. So we're going to have to take a look, and we already are taking a look at some of the changes that we can make on the skilled nursing assessment to meet the uniformity clause and making sure that providers are not harmed in the process. I know right now we are currently taxed based upon Medicaid bed days. The law and the rule actually state that that cannot be one of the instances of what we're taxed. And then of course we have to be taxed in uniformity. We're also taking a look at the MCO assessment. We know that that is a huge funder of the Medicaid program, and that's going to affect us. So although we might not have a key role in that discussion, we're taking a close look at it to see where that might lead. And of course, we're always happy to be a part of the conversation if you like long-term care's perspective. And then next, we're looking on a broad topic. We've already had discussions for the General Assembly. This is a lot of changes happening for Medicaid program. Funding is possibly going to be reduced resources. What is it going to look like if the General Assembly has to vote on revenue, and where is that revenue going to go? So IHCA is already taking steps on how we can help provide information to legislators, but also set the tone for providers as well. And then of course, last but not least, we're talking to our providers and how it'll impact them. Some of these changes, again, on the assessment, funding, resources, what they can expect in the next couple of years, because it will be phased in a little bit, but as we know, these assessment conversations, they take a long time to work through the details of it. So that's what we've done so far at IHCA, and we're going to continue to do.
So Jill, I want to go to you on this question, just from the insurer's perspective. How are you preparing for these changes?
Yeah, good morning, everyone. If you're not familiar with IMDIP, we represent all 6 of the currently contracted health plans with the state of Illinois, so that includes Blue Cross, Aetna, Molina, Meridian, County Care, and Humana. I think I got them all. And so we really try to look at this as an ecosystem. As you can imagine, the Medicaid health plans are really responsible for managing the care, coordinating the care of the individual throughout that continuum of care, regardless of where they are in that process, whether they're healthy or they're in an institution or they're managing a chronic disease. Whatever the case may be, the plans are responsible for engaging with those individuals. So we're looking at it from that perspective. I would say the first sort of glance at it is to put it into different buckets, but doing it on a timeline basis. When does something go into effect, and when will we have to deal with that as a state? Whether the General Assembly has to be involved, whether it's a budget discussion that needs to be had. Obviously, as Ashley mentioned, the MCO assessment is one of those issues we do think we're going to have to address because of the uniformity standards. So that will probably be one of the biggest ones coming next General Assembly. And then just over time, rolling in those changes. And so what does that mean? Anytime there is a shrinking of revenue in the state of Illinois for the Medicaid program, it's going to hit somewhere. It's going to hit benefits, it's going to hit eligibility, it's going to hit providers, and all of that will have a detriment to the numbers that we're serving, whatever capacity that means. If safety nets are getting less money, if critical access hospitals are getting less money, that means less access to care for our members, that might be wait lists. That may just mean greater pressure on that community to do more with less. Because as Ollie mentioned, it's not that it gives up their responsibility to continue to see those people that walk through the door. They have a grant and they have to serve people, but that just puts additional pressure on them to continue staffing at those levels and even seeing their Medicaid patients at that current level. So engaging with our provider networks, having an understanding what that impact is going to look like and how we can work together to try to make sure that we're producing those quality outcomes and that quality of life over time is really going to be key to where we need to go with this. So I would say that those are our initial concerns, as we maneuver through the timeline and what the actual impact is.
AJ, I want to go to you on this one. Just kind of, how are you and your members preparing for the changes?
Yeah, thanks, Ryan. All right, here we go. Can you hear me? All right. Thanks for the question and for the invitation to join this panel and having this very important conversation with all of you. I think the director said it, right? These cuts are deep and dramatic. And as Jill said, they're going to have a devastating impact across the provider continuum. And so our members, working closely with IHA, I would say three things. Right now, our members are analyzing what these changes and cuts mean for their hospitals. And so that analysis is taking place. I know one hospital, large community hospital outside the Chicago market, is saying that when they do the math, it's a $175 million hit to their hospital, one community hospital. Second, they're evaluating their options, right? What are we going to do in response to these cuts that are dramatic and deep and will have this devastating impact? And that gets to services. What services can these hospitals continue to provide and continue to be sustainable in serving their communities? And how do they make some adjustments around not only service lines, but the jobs that they create in their communities? Because something's got to give when you're talking about $1 trillion in cuts under the Medicaid program over a 10-year period. Third thing, they're going to continue to advocate. Certainly at the federal level, we're going to try to do everything we can to mitigate or delay these cuts. We're going to continue to work with the governor and the General Assembly on key issues to drive revenues to hospitals and FQs, like the 340B legislation that we have pending in the House of Representatives. And so we're going to have to be very creative. We're going to have to be very diligent and vigilant in working together with other provider groups across the continuum to make sure that hospitals and other providers have the resources they need to keep those services and jobs intact.
Now, Stephanie, obviously you're one of the people on the panel who do not have members. But I do want to kind of switch it up a little bit and just kind of ask you, how do you expect these changes to affect patients and the Medicaid members here in Illinois?
So we I guess, do have members in that it is our clients and our patients and the communities that we work with who are your guys, patients and clients and recipients and members. So Protect Our Care Illinois Coalition, which many of you are a part of, is a large coalition, including the Shriver Center, that we've led since the first Trump administration and the repeal of the Affordable Care Act. And we kind of relaunched and fought the federal changes as much as we could. And now it's time to work with the state to do what all of you have said, which is to mitigate the harm as much as possible. One thing we haven't mentioned is the harm that's going to come to immigrant communities. Some of the most drastic changes that come the quickest are to immigrants seeking care and eligibility. So one of the things that we're working on now, and actually Protecting Immigrant Families National is having their big conference in Chicago right now, is how we make sure that as these changes go into effect for the marketplace and for Medicaid, that immigrants who were eligible and will soon lose eligibility are protected if they have some sort of option, free care, state, other programs, community health centers, and getting that message out to a community that's under so much pressure in Target right now and is facing so many difficulties from the federal level, and really on all fronts, and are, in some sense fear of seeking care given what's going on. So that's something that's like very top of mind right now. But we also, at the same time, are looking at things like the work requirements, which will be the biggest hit.
Yeah. Definitely, and we'll touch on the work requirements in a little bit, but Stephanie, let's stay with you. As we talk about this, the immigration population, obviously Illinois has ended its program for Medicaid-like coverage for some adults. The program for seniors, TBD, it sounds like. And I'm just curious, kind of, what steps can there be taken to make sure that these individuals can still have coverage, still have health insurance? What's there to help them?
Yeah, so Illinois still is a leader in the nation for serving immigrants. We were the first state in the nation to cover children back in 2006. Some of my colleagues were here and worked on that then. And I hope the state always keeps that commitment. I think it's always been a very bipartisan program. We were also the first state in the country to cover immigrants regardless of status postpartum to 12 months. And that also still exists, pregnant women, of course, and seniors. So for the adults who have less coverage, we have worked really closely with them to either enroll in any other coverage that they're eligible for, and also to be able to seek care in an emergency situation in hospitals, which is still available, it is still covered, but puts additional pressure on these hospitals and on community clinics at the same time that we're seeing all this other pressure. So we're working with people kind of one by one, all the time, in order to connect them to coverage. We do hope that the state and the legislature, even as all these financial pressures are happening, looks for a solution, because otherwise those financial pressures just end up on the counties and on the hospitals and on the clinics. So I think we do have to come together and figure out some solution to the issue of healthcare access for immigrants.
Absolutely. Ollie, I want to go to you. I know I've talked to you and your team in the past about some of the challenges, not only with the 340B program, but with the Medicaid-like coverage for undocumented individuals. And I'm just kind of curious if you could talk about just kind of how this whirlwind is kind of affecting all your members, and just kind of, not only that, but also you mentioned the possibility of closures, or, and I'm just curious if you could maybe talk a little bit about kind of, if we have an idea of how many are at risk here.
It's a painful subject for me. I don't want to be anecdotal, but for some of our health centers who have a larger proportion of that population, HPI population, the impact was devastating. And some of them are trying to figure out what it's like, what it will be like to even keep the doors open in some instances. While we appreciate that at the end of the legislative session last year, the legislature did forward us a small amount of money, but it's not consequential enough when your rates are underfunded for the patients you serve. So it's a mixed bag, really. To be honest with you, the impact, and again, I don't want to understate it, for some of our health centers is pretty significant. It was, I think, if I'm some 15 to 30% hit. Again, and I don't want to call out health centers because it impacted certain health centers differently. But again, it's in the grand scheme of all the things we're batting away. And you heard AJ talk about 340B, which we got really close and thought that may be a little bit of a stopgap, a little bit of relief for our health centers, but yet we couldn't get that done. session. So it's the same thing. We'll keep fighting, keep advocating, and looking for solutions. But right after that, there's really nothing that's going to make those health centers whole. But they can still do what they can to keep the doors open.
Definitely. Actually, I wanted to go to you real quick. There was a report earlier this summer from Brown University School of Public Health that identified 93 Illinois nursing homes at risk of closure due to the legislation. And I guess what's the general feeling right now about how this will affect the viability of nursing homes? And does that 93 homes at risk seem like an accurate number to you?
So that's a great question. I think I would start off with the conversation about closures in nursing homes have been around much longer than this bill actually being introduced and passed. This was pretty much right before COVID. We started to see nursing homes close due to low reimbursement, high regulatory standards, and of course the reduction in workforce. Then COVID hit, and that was a gut punch to the long-term care community specifically. Not only because they were overworked, because it was the population that got hit the hardest, but then of course we're struggling with workforce in general. So that conversation, I did take a look at that list. I think it's hard to point out exactly which homes will close, but I think I can make the overall statement that with the high regulatory standards that we have, with staffing requirements, with workforce, with the punitive fines that we face, nursing homes will be closing, especially the rural ones. It's certainly a struggle that we see primarily in the rural communities, because on top of that with workforce, it's hard to bring people in to those rural communities. So I would say yes, I wouldn't restrict it to a list.
Yeah.
I think in general you can say a lot of your, what you would call mom and pop or individual nursing homes that you see out there, they're starting to sell. They're starting to sell to some of the bigger management because they just can't make it anymore. And this Medicaid bill certainly isn't going to help the situation.
AJ, I want to go to you on this. There's been reports and you've discussed that there's 9 Illinois hospitals that have been deemed at risk for closure. Is that number still seem like pretty accurate? And then also just what is the timeline for when these hospitals are going to need to know some sort of financial certainty, as far as what's coming from funding at the federal level and state level to determine whether or not they can stay open?
Yeah, it's an important question, and I appreciate Ashley's response too. We think about some of the vulnerable hospitals across the state, certainly small and rural hospitals. Pursuant to your question, there's a list that was developed for every state in the nation. We have 9 small and rural hospitals on that list. And in talking to some of those hospital leaders, there are significant challenges maintaining their independence and continuing to serve their communities. And many of those communities are what we would consider vulnerable communities. We also know in urban centers, right? We have had conversations with state leaders and with our members. We think about some of the challenges of independent safety in the hospitals, right? So I think, as Ashley said, rather than look at a list, I think generally we have real concerns that hospital closures, which have happened in this state, could certainly continue to happen because we know there were pressures coming out of COVID, an increase in costs, whether it was labor, supplies, prescription drugs, relatively flat reimbursement rates, continual care practices that are concerning and challenging around denials. So how do we continue to work with our elected officials to make sure that we have the resources that hospitals need to keep those service lines intact? Because at the end of the day, Medicaid sometimes is considered a budget line item, but we know it's about people, right? And it's a lifeline to vulnerable people and communities, and we've got to do everything we can to shore up the support that the provider community needs, certainly hospitals. And to some of the points made earlier today about, when we see people lose coverage, they're going to continue to show up in our emergency departments, right? And we have a legal and moral obligation to provide care, and we will. But that means more uncompensated care and even more pressure on our hospitals to keep their doors open, to keep their services intact, and to keep their workforce intact.
Definitely. Director Whitehorn, I want to go over to you for a little bit here. And let's start with the discussion that's been touched on a little bit, but the law tasked states with implementing work requirements for Medicaid members. And I wonder, first of all, if you could just tell us a little bit about the provision itself and kind of how the state is, what steps it's taking right now toward this implementation.
Sure. I did just want to some of the
Oh, yeah,
questions
please,
you've been asking, and then I'll talk about work requirements, but I don't want to underestimate what the federal government is doing to attack immigrants. So, we had to make a hard decision last year because of a budget situation we faced in Illinois, let alone what's happening at the federal level. But I think, aside from what's in H.R. 1, there's been reports, I'm sure people have read in the news, about federal CMS sharing data with DHS and ICE, and then also federal CMS doing pretty significant administrative reviews of how states are spending how we're claiming for the federal dollars that we do get for emergency services to cover people who are not citizens. And, it's not a coincidence which states the federal government is going after in those reviews. So it's throughout the federal government and the administration right now. But to go to work requirements, so yes, for the first time in the Medicaid program, we have to implement work requirements. So people age 19 to 64 have to prove that they're working or 80 hours per month. There are some exceptions for people with disabilities or people who are caregivers, but only if they're caregiving for someone who's age 14 and under. There's some other smaller exemptions as well. But they're gonna have to verify. We're going to do verification up front when people are enrolling, and then every time they go through redetermination. And as I mentioned, now that ACA population, which is a huge chunk of who will be having subject to work requirements, will have to do it twice a year. We are looking at a number of things to implement this. As I said, our system, we didn't have work requirements. So we have this huge system that is, still could be improved upon even without the work requirements that we have to add in to make sure that we are doing this all properly, and we want to make it as easy as we can for the customer. So we're looking at things that we wanted to do anyway to improve the system. We don't have a mobile app, a friendly app for people to enroll. Like we need to do things like that. We want to try to make even more of the process automated so that it's easier for people and it's less of a burden on the caseworkers who the state employs. But we are looking, so there's the whole technology piece. How can we use AI? I mean, there's, a lot of companies now, like how can people upload documents that are automatically read? I mean, it's this type of thing, but this is for January 1st, 2027, and even though H.R. 1 allows for a good faith or a waiver to delay implementation if the state is making a good faith effort, federal CMS has already said they are not inclined to grant any of those waivers. So that's a year and a half. That is not a lot of time in government bureaucracy to make these huge changes, which is why we're really looking at where we might have to do emergency procurement, what else we can do to speed that process up. And then, it will involve hiring more people at the state to process this. The state is going to have to spend money to do things that will ultimately result in loss of federal funding. To implement work requirements. And the last piece I'll say, I mentioned this earlier, is how can we better communicate with our customers? I mean, we are not, the state is, a big government entity. We learned a lot during the unwinding from the public health emergency about better communication. We texted with our clients for the first time, I think. But we're really going to have to partner with, organizations like Shriver, community-based organizations who are on the ground and work with our customers on a daily basis so that they know what they're supposed to do, so that they don't lose coverage for administrative reasons. About 68% of current Medicaid customers in Illinois, 19 to 64, have some kind of income. Most Medicaid recipients work, but if you look in other states that have implemented work requirements, people lose coverage for administrative reasons. So you have people who should be getting coverage and they just can't meet this administrative burden, losing coverage. And we think our estimates are that somewhere between 270,000 and 500,000 people could lose coverage just because of the work requirements.
And Director, I want to stay with you quickly. When are you expecting guidance from the federal government on how to implement this and kind of some sort of guidance on this?
We don't know. I mean, we meet with our associations frequently. There's so many different groups who are trying to bring states together and learn as much as we can, but the feds have not been very forthcoming. You know, I think they're honestly scrambling too. They have lost a lot of staff. At least what we see at federal CMS, and of course we look at it, I mean, all the things that the Trump administration did to get people to leave or force them to leave has really impacted the operations of the federal government. And so, you know, we ask frequently, and not a lot has been forthcoming about when we will be receiving guidance on different pieces of HR1.
Jill, I want to go to you on this question. Just how are insurers preparing for the work requirements, and how might this impact insurers and your enrollees?
Yeah, so luckily we did have the PhD in learning, and I think it was one of the best collaborations that we've had with the state in terms of education campaigns, reaching out, messaging together, getting our advocacy organizations involved as well. Empowering the MCOs to update addresses appropriately, engaging with our PCPs so that if somebody's coming in, always reminding them, hey, don't forget to change your address so you can get your packet and get that back in. And I would anticipate a similar thing related to work requirements and the 6-month renewals. We don't know exactly what that looks like yet, but I'm guessing that we'll be working closely with the department on that as well. But I think the biggest concern for the plans related to these new policies is churn. It's just people coming on and off is so detrimental to the idea of continuity of care. And once you've got that person engaged in care coordination, the idea that then you would lose them for administrative reasons, and then they may come on with a different health plan, and then have to go through a whole process of assessments and all of that again. I think that's one of the biggest concerns, because you really just lose that impact and that relationship with that member. It's also a nightmare for providers trying to decide, you know, who am I billing on this day? Who am I getting an authorization from? As people, you know, come on and come off and change. And so, you know, I worry about that too, because that's just extra unnecessary work that they have to do that as well. And, you know, I think along with that, back to the issue of like the immigrant population and, you know, they're scared, right? And so even though like the seniors still have coverage, they're not going to their appointments. Especially if they're concerned that ICE is going to be in the parking lot when they get to their FQHC or wherever they're going. So this overall idea of being able to work with our members, engage with them, manage care coordination effectively has been impacted across the board. And that goes for things like vaccines as well. I mean, all the rhetoric right now around vaccines and just your normal, you know, annual screenings and well child visits and all that, it's all being impacted right now by all of these messaging that's happening, and it's just trying not to be I'm trying to stay positive, but it is a ripple effect through the healthcare system that we are all going to feel, and I think that's sort of our biggest concern right now.
Absolutely. Stephanie, I want to go to you. As states like Illinois move forward with the work requirement implementation, just what are you wanting to see? What are some of the steps they can take to ensure there is the least amount of impact on members?
Right. I mean, we've learned something from the couple of states that have tried to do this, and I think states around the country are going to do things that Illinois has been successful, you know, what Jill mentioned with the coordination of managed care companies and providers, with advocacy groups, community organizations, as the director said, tech, mobile apps. You know, we know the population, how they largely communicate. I don't know that there will be a lot of policy options to make this any less bad. You know, to the extent we will be able to do some sort of work around the edges of who's exempt and things like that. I think the federal government has until June 2026 to even issue that guidance. And as the director said, I don't think we'll be a state that's, you know, viewed very favorably in waivers or exemptions, and I think the state, I understand, will have to be very careful, you know, in following the federal rules. To that extent, though, I think there are things that some states are looking at that might be interesting to look at, like work programs and training and vocational and high school extensions and community colleges and community service programs for people who may be able to meet exemptions, exceptions, or the requirements themselves, and could have a twofold, you know, purpose. So I think that's something maybe broad and innovative the state could look at that's more positive. I think, you know, call centers and online cases and being able to manage your case and texting and all those things have already been mentioned. In some sense, I think we're most worried about churn, what Jill said, which is, you know, the people who are low literacy, unhoused, really not connected to providers and kind of come in and out of the system already, are the ones most likely to fall off for administrative reasons, not connect even by text or anything like that, come back to a provider, and then maybe not be able to get back on coverage, depending on how draconian the look-back periods and things like that are. So we are really worried about that, because I think that's the biggest concern, is people just churning on and off coverage, which we largely solved during the pandemic, and the state did such a good job at it, that we're just gonna have to keep whatever pieces we possibly can for better times.
Definitely. Director Whitehorn, I want to go back to you, because another notable provision in the law is a decrease in how much states are able to pay through state-directed payments. But what impact do you think that's going to have on Illinois, and how much funding are we looking at there that's going to be affected?
Yes, this coupled with the provider tax provisions are really where the budget gets hit in the later years of implementation. So right now we use state-directed payments as a way to pay certain providers, where we can direct more specifically how they're paid, separate from claims payments. The largest by far state-directed payments we have are to the hospitals through the hospital assessment program. But they're really, you know, I think there was a narrative created at the federal level that, you know, sort of gave a bad look to provider taxes and state-directed payments. But it's really a way that the Medicaid program has for many years recognized that rates don't necessarily cover costs for Medicaid providers, and so this is a way to get Medicaid providers, especially hospitals, paid closer to their costs. We got some exciting news last week. I think people know that we had put in a request to increase the state-directed payments that hospitals get based on a rule that was finalized under the Biden administration that was really created with the belief that hospitals should be paid closer to their average commercial rate. And so we, along with many other states, scrambled to put in our request to the federal government for approval, and we just found out last week that it was approved. So it's very exciting for the hospitals, but it does mean there'll be more of a cliff when the state-directed payments have to go down. So HR 1 says that starting, I think, in 2028, they can't be more than 100% of Medicare rates, and there's sort of a ramp down. So our preliminary analysis is that we think that will mean at least a $2.5 billion loss in the state-directed payments just for hospitals. That's, you know, of course, in addition to the the losses from the provider tax hold harmless provision, which, you know, we can talk about that or not, but that also starts in 2028, and that's where the revenue that the state gets from the hospital assessment and the MCO assessment is going to have to decrease over time to the tune of, you know, billions and billions of dollars. And so hopefully that's where all of these national organizations are continuing to advocate with Congress to try to change those provisions or push them off even more.
Thank you so much. And Director, you just teed me off for my next question, so I appreciate that. Ollie, I want to go to you. You mentioned you're headed off to DC here, and I wonder just if you can kind of give us a preview of what those conversations are going to look like. What's that advocacy going to look like when you and your partners go there?
Well, another good question. So, you know, I say before what I call BOLA, which is one way to bill, or you want to call it, or HR1. I think all my colleagues around on the panel here, we have national associations, trade associations. So you think my national association, AHA's national association, Shield's national association, all of us collectively working together to impact HR1. What did we get? Mm-hmm. If not for the Senate parliamentarian, who knows what would have happened, right? That just shows you how tough it is to have conversations in D.C. But we won't stop. We continue. We've had meetings with, of course, there's a big organization now with a administration for Healthy America. But we've had conversations with Dr. Oz at CMS about things we could do to be creative, right? There's still, like I say, they value the work we do. Yeah. Sometimes they have a different way of showing it. But you know, work requirements. Mm-hmm. There are states who've been doing it. We've been in work groups with states who've done it. Arkansas tried. I think there was a 25, 1 in 4 people lost coverage, and I was in Arkansas in 7 months of implementation. New Hampshire, they suspended their program. Mm-hmm. So we have, you know, data points that we can share, and we do share to say, well, if you're going to do this, despite the impact we told you it's going to have, and don't even listen to us over, could you at least look at it this way, right? You know, we turned in comments on what the Rural Health Transformation Fund should look like, and have conversations of what their expectations are. Looking at, I hate to say this, you know, MAHA, you know, are there things there that we could align with, right? Are there expectations or things we could do? But to be honest with you, you know, and I try to stay out of the political realm here. It's very tough to have conversations with an administration that is determined to do things the way they see it. But it doesn't mean we stop. We look for opportunities, and again, as I started out talking about, for us, across the nation, over 30 million patients get their care at FQHC. So in Illinois, it's 1.5 million people. So we think about these things, and we continue to have those conversations. It is, what can we do to make things work? What can we do to delay things? As much as they say, we're not going to probably entertain a delay on the work requirements and those kind of things, really taking to them. We've had twice now the new administrator for primary care come to some of the health centers in Illinois. Secretary Kennedy has been to our health centers. It's just really showing them the value of what we do and letting the data speak for itself. I'm not sure that's going to change anything on that front, but we continue to advocate and continue to. So it's the same conversation tomorrow. I'm sure Durbin will tell me the same thing. Great job, Ollie, but this is what's going to happen.
Right. Actually, from your perspective, kind of what's the conversation like when you talk with your, you know, federal partners and some of your other organizations? What's the advocacy look like for the long-term care perspective?
Sure. So, kind of wanted to start this conversation off without getting daggers from everybody else on this panel. That SNFs, we weren't directly impacted. We didn't directed payments. We don't receive directed payments. So that wasn't a direct hit for skilled nursing providers. In fact, this bill actually helped us out in the sense where they delayed a national staffing mandate that would have increased costs and quite honestly was just an arbitrary number set across the continuum of care instead of actually looking at patient-centered, what the resident needs when it comes to staffing. That's certainly something that IHCA wholeheartedly supports. So this bill actually did us a little bit of a favor in that sense, where it delayed it for 10 years, and of course the courts, they are ruling against it as well, so it could possibly be dead. But when it comes to the federal side of things, I think they did their job on the skilled side of it. I know ACA's been working really hard on making sure that those provisions are in place. On the federal side, I think we can also partner still with the hospitals and with everybody up here because it's a full continuum of care. We still receive residents from hospitals. We still receive residents from the community, and making sure that that coverage does not skip a beat is really important. On the state side of things, again, we are working more on as the director stated, 1.5 years is not very long when it comes to government and getting things done. So although we say that these provisions, the assessments are pushed off for another 2 years, our policy team's already modeling what is the nursing home assessment going to look like, where it supports quality, but it also doesn't harm providers in the process. What does it look like for rural communities? We're really drilling down on the state side of things for skills because that's really where it's going to impact us as a community.
Absolutely. We barely scratched the surface, but somehow we only have 9 minutes left. So I do want to open this up for audience questions if there are any. If you have a question, please raise your hand. I'll call on you as I see you. And if you could, just please let us know who you're directing your question toward.
This is Patty, one who wants to answer. We didn't chat Illinois, of course, the DHC state, so just curious if there's any thoughts, perspectives on what to look out for individuals seeking help.
You want to take that?
Unless I'm misremembering, I don't think there's anything directly impacting funding for behavioral health in Medicaid. There certainly were things proposed, I think, through the pocket budget and other cuts around funding, like through SAMHSA and other areas. I think this goes to the larger question, which we didn't talk very specifically about, but the cuts to the changes to the provider taxes, as they are now, will literally mean double-digit billions of dollars over the 10 years that will be lost. And so we don't know how we're going to implement that, but to be clear, no state has the ability to backfill that amount of funding. I think that's where specific lines of services, we're going to have to be looking at everything to figure out literally how to balance the budget and move forward. But it's going to require some really, really hard decisions. We have not even scratched the surface of what that could look like, and I don't want to scare people. No decisions have been made, but I think that's where you would see all services, including behavioral health services, potentially at risk. Meanwhile, we do continue to operate the CCBHC program in our building it out and adding providers to it.
Okay, thanks. I'm glad we were able to touch a little bit on provider tax. That is obviously another key issue. Is there any other? I saw you, and then I'll see you.
There was legislation introduced in Congress last week that restored and reconfigured funding for safety net hospitals. Questions or anything? Could you maybe share more about that bill and what might be the potential impact?
Yeah, I appreciate the question, and we're looking into that piece of legislation and if it has legs. But as I mentioned earlier, safety net hospitals, particularly vulnerable, coming into the negotiations on HR 1 and even more so coming out of those negotiations and that bill becoming the law of the land. So we're going to be tracking that very closely at the federal level, and then also having important conversations at the state level around safety net hospitals.
Go ahead.
Yes, hi. Cheryl Jackson from My Own Doctor. I want to first thank HFS and the state for your leadership around preventive care and educating the Illinois Medicaid population around preventive care. I'm in churches all the time, in communities lately, and I'm saying, don't get sick. That is the key. But to be really engaged in your preventive care. My question is around better coordination and integration with social service agencies that are, driving or responsible for workforce development, all the other sort of, social determinants of health that we know impact health. The Legislative Black Caucus some time ago passed, legislation that called for better coordination between Medicaid, Medicare, and social service agencies. And while it's sometimes difficult to engage this population around preventive care services, they are at these social service agencies getting their benefits. And some integrated and hyper-coordinated sort of coordination between those agencies, their intake processes, and pushing for more preventive care or other services, Medicaid services, education services, I think could be helpful, particularly around the administration issue. Can you speak to that?
Yeah. Want to take that on?
I can.
Yeah, what you guys are.
So we always say FQs are sometimes the best kept secret, and for all those things you mentioned, I can think of a number of FQs, and some of my members are in this room. So that is the goal, right? Is to really provide comprehensive, fully integrated care services to our patients and the communities we serve. And we all do it differently, so different flavor wherever you go, but that is our mission, that's the core of what we do. But as you heard today too, all those things come at a cost. And all these stressors, all these little things we talk about, we talk about work requirements, there's, apart from the implementation, there's a burden on the provider itself, not just a financial burden, the capacity of being able to provide those services, because you heard about the churn, but that churn also means a burden on the provider, and we think about it, it was about 5 years ago, we came off of a very, very, very serious pandemic, right? So still recovering from that, trying to recruit to backfill some of those positions. But your question was, do we do that? And we do. We do it very well. How well we'll do that in this environment, it's left to anyone. But we continue to fight. We continue to stay to the core of our mission. But it is the core of what we do, and it's in our DNA to continue to do those kind of services. It just gets harder to do in this environment.
I was just going to add, I think the state was, under this administration, sort of on its way to doing even more of that in a number of ways, including getting approval to cover home visiting, community health workers, doulas, lactation consultants through Medicaid, and I know part of that was in the Black Caucus Miller bill. And so those are various stages, but being implemented. We also got approval from the feds a year and a half ago almost, anyway, for our health-related social needs healthcare transformation waivers, and that will allow us to cover some of these other types of, non-direct medical, housing, nutrition services, all of that sort of contributes to the type of care you're talking about through Medicaid. That takes time to get up and running, but we are still planning to move forward with that. And lastly, I think this is something we heard loud and clear when we did listening sessions last fall in anticipation of having to re-procure our managed care contracts for the first time since the program began. And so I think you'll see some more, I think there'll be opportunity there to improve on care coordination and really emphasizing preventive services.
Okay. We have time for one more quick audience question. Yes, Representative.
I'm going to try to project here. Hi, everyone. Thank you so much for this great discussion. State Representative from the far northwest side of Chicago. So how do I what you just said about how the churn and the administrative burden is going to have a deep effect on professionals really resonates with me. So my question is, like, given all this is coming and we are all trying to manage it, what under the big umbrella of what you all do, which is obviously intertwined with state government and state funding, what can we stop doing? Like, what can we take off the table because we are all going to be dealing with this intense burden, and will people be really hurt? Yes. But will we get through it? Yes. Will we have a different Congress and a different president at one point? Yes. But not immediately. So, like, I'm thinking through the lens of, even as a General Assembly member, what can we stop doing to decrease the burden so we can focus on getting through this while making sure we're doing everything we can to take care of people? So is that something that you all are thinking about already? Kind of what can we take off the table? And do you think that's kind of a useful thing to think about?
Sure. Anyone want to take that?
I'll take some of it. so obviously I talk about the administrative burden and being able to have the capacity to provide these kind of services. One of the things we sat down with the department about credentialing providers. When we get new providers, the speed at which we can get a credential into the system so they become billable kind of things. Those are probably, that to me is a low-hanging fruit in terms of, can we reduce the burden on providers so you're not chasing down those kind of things. And we've had some very fruitful conversations on how we can do that to streamline the process. But I think that's where the opportunity might be in the future. But I agree with you, Representative. There are things we should all collectively be thinking about that we can take off the table, or to at least make things easier. I just put one example. It's really for us. If I look at my community, my health centers is, hey, I finally got a provider. I'm going to pay them a lot of money, but it's going to take me another 6 months to get through the system before they become billable. So can we face that problem? And we are having conversations on what it'll take to streamline.
Great. Anyone want to close this out here? AJ?
I was just going to add to, I think my microphone's no longer working. No, there. I think it's a great question, Representative, and to Ollie's point, what can we do, either stop doing or do more efficiently? Credentialing is certainly on that list. So is the Illinois licensure process, and I know that there's been an investment in our licensure process to get it into a modern era, right, with a much more robust and electronic platform. Those are really good examples of how we can work together to either stop doing something that's inefficient or drive greater efficiencies for the benefit of providers. Obviously, with the ultimate mission being, how can we make sure that we're there to serve our patients? And the last thing I'll say is, when we talk about what services are at risk, the director was going there, right? Obstetrics, behavioral health care services, trauma services. Those are some of the at-risk services when we were all talking about the impact of this H.R. 1 on providers and what it means for the people that rely on Medicaid as their source of health care coverage.
Fantastic. Great. Well, we are a few minutes over now. Obviously, we can keep going, but I'll let you all get on with the rest of your day. I want to thank our fantastic panel for joining us this morning to talk about this issue. Thank you guys so much for all being here today. I want to thank everyone for joining us today. Just a heads up, our next in-person event is later in October. It'll be right here. More information will be in our newsletter, hopefully by the end of this week. So stay tuned for that. With that, have a great rest of your day and a great rest of your week. Thank you so much, everyone.